Good morning. Welcome back. My name is Kendra, and I'm the chair of Fourth Trimester Arizona Board of Directors. I'm going to be moderating the session, Integrating Mental Health into Primary Care for Parents and Children. So for those of you just joining us, I want to go over a couple reminders regarding Zoom. So first off, our summit today is recorded. So we ask that you please keep your microphones off. You're welcome to have your camera on or off throughout the day, but we encourage you to have them on if you're asking questions. We're going to have a Q&A portion at the end of each session, and for those times and for sessions that are more interactive, feel free to use the hand raise emoji to request to speak. If you need help, we have a tech support person in every session. Their name is at the top of your chat box. You can direct message them any questions you have. And the chat is a great way to interact with the other attendees in the session and with the speakers. So please also review our legal disclaimer found on your screen. And here are financial disclosures for the talk. Thank you. Okay. Up to 75% of primary care visits include mental or behavioral health components. Fully integrating behavioral health into primary care is the gold standard for care. Today, we have brought together 4 panelists who are leading the charge in integrating mental health into primary care to improve maternal and child health. Each practice comes from a different area in Arizona and have done this in slightly different ways. Dr. Alina Bowman is board-certified pediatrician and international board-certified lactation consultant at Tonke Verde Pediatrics in Tucson, Arizona. She has a passion for supporting new mothers in her practice after her own experience with postpartum anxiety. She currently helps run a free postpartum support group through her practice and serves on the board for Fourth Trimester Arizona. Ashley Brubaker is a licensed master social worker and Napa UC Davis Infant Parent Mental Health Fellow. She received certification in perinatal mental health through Postpartum Support International and is currently working toward her IBCLC through the ASU Academy of Lactation program. She currently works as a behavioral health consultant with Canyon Pediatrics and Family and the breastfeeding coordinator with WIC. Elizabeth Frenette joined 0 to 3 in 2018 and currently is a senior policy analyst for Healthy Steps. In this role, she leads Healthy Steps sustainability efforts in New York by working with health systems, key stakeholders, payers, and policymakers to secure long-term funding for service delivery to children and their families. She serves as a subject matter expert on Healthy Steps growth and scale and supports the Healthy Steps network through direct technical assistance with billing and coding for Healthy Steps related services. Deanne Davies currently serves as a pediatric early childhood program consultant and trainer. Deanne served as an expert on program implementation and training for pediatric outreach programs for more than 24 years. She has consulted with national early childhood organizations, supporting the development and implementation of models designed to support postpartum depression screening in pediatric outpatient clinics and resident training programs, and supporting the development and implementation of reflective practice. Deanne holds a Master's of Science in Counseling Psychology, Child Development, and a certification from UMass Boston in Infant, Toddler, and Parent Mental Health. We are very excited to have each of you here today to speak with us. I will be asking each of the presenters a few questions. After the questions, we will be opening it up for Q&A. Panelists, for this first question, you each have 3 minutes to answer. Question 1 is, why did you choose to integrate mental health into primary care in your area or practice? . Who wants to start?
I'm happy to start. It's where the moms show up, right? They bring their babies in, and so it's just the best opportunity to be where the moms are.
And I can say that 22 plus years ago, when I became the first Arizona Healthy Steps specialist at Phoenix Children's Hospital in their residency training program, I quickly learned that Healthy Steps has a maternal postpartum component and minimal training for how to deal with it. And I quickly learned residency training had absolutely zero training in that topic. That was 22 years ago. Things have improved a bit. So yay for them. But it was really the moms who taught me how important, and the dads who, or other partners who taught me the importance of the perinatal period and the impact of PMADs. So I searched and I found Postpartum Support International, and I became a certified trainer and immediately was asked to serve on the Arizona representation for support coordination, and accepted that. And there we were. So I felt like our team was trained. We were able to share that knowledge and skill with residents in our program. And most of all, we were able to meet the needs of the caregivers of our babies. And that carried forth and just grew with a lot of resistance, but it grew. It's a hard institution to impact with change, but I just didn't stop, and neither did my team. And so that it became a normal means of practice for our providers and for our Healthy Steps team. And that's where we started 22 some years ago.
I can go next. I think for us as a pediatric practice, we just saw a really significant need for both children and adolescents, but also moms too. Like Elizabeth said, you know, we're often the ones as pediatricians seeing moms at day 3 postpartum all the way through the first 2 years, whereas sometimes their first OB appointment isn't until 6 to 8 weeks after birth. And a lot of times postpartum depression and anxiety has already started to present itself. But definitely as pediatricians, we're finding that the demand for mental health services is increasing each year for children and parents. And the wait lists in the community get longer and longer.
Also being in a pediatric practice, just kind of piggybacking on what was already kind of been said and shared, is that so my work isn't only with moms and babies. I work with you know, all of prenatal up to older adult, but I find that the biggest support has been helping families to figure out what resources are in the community or where these parenting groups are at, or helping them to feel that they're not alone, helping to destigmatize, you know, the primary care or pediatrician they usually already have a rapport with. And so it makes it easier or less daunting sometimes to meet within a space that's already comfortable or familiar, and then being able to kind of handhold a little bit as to, you know, are we needing, you know, a higher level of support, or is it, you know, some brief intervention, psychoeducation we can kind of help work through. But I do think that it has been something that's made a big difference for our patients to help support them through that time.
Awesome. Thank you so much for those answers. Okay, for your next question, you have 5 minutes each to answer. Question 2 is, how did you integrate mental health into primary care in your area of practice? So, Can you speak a little longer about that? Whatever order you want to go in.
I can start because ours is a fairly new venture and we've learned a lot and continue to learn a lot along the way. We're in, and I have slides I can share, but I think I can just chat about it. So we're an 8-physician group of pediatricians, and we started integrating mental health services into our practice 2 years ago. And that really, I think the pandemic was the impetus for that, because we started seeing just exponentially increasing number of anxiety, depression, behavioral issues, and longer wait lists in the community to get those patients seen, and especially patients in crisis, teens and adolescents with suicidal ideation or severe depression. They can't wait several months to start seeing a provider. So we looked at a couple of different models and ultimately settled on a self-pay model, because we could not find that at least starting up, insurance was going to cover the cost of having 2 in-house social workers. So when we looked at contracts, we would have gotten about like 40% reimbursement from insurances versus having a self-pay. And so we had 2 licensed clinical social workers on staff to see patients during office hours, and also available for crisis appointments for last minute intervention for kids who were in severe distress. And then they also were available to see our postpartum moms or dads who were struggling as well. And they provided more of like a bridge to the community. So we limited sessions to about 4 to 6 sessions, hoping that in that time, either it would be very problem focused and we could work through it, or get them established with somebody for more long-term therapy by that time. And then we have a conference room on site, so we were able to do our visits there. We did run into noise as a factor with being a pediatric practice, so a lot going on in our office. So that was a little bit of a hiccup there. And then we've kind of expanded it to include group therapy. So we started offering groups for age ranges, and different topics. And then we have had 2 summer camps focused on mental health and skill building, and a lot of fun things for elementary and then more teenage kids. And then myself and one of our social workers started a postpartum support group that was free to the parents of our patients. And that was run twice per month via Zoom. Full disclosure, we are restructuring things because financially that for the time being, we had months where we barely broke even. Most of the time we operated in the negative, even doing a self-pay module. So we're currently in a transition period. So anyway, I have a lot more to share as far as what we've learned, but that is how we initially set things up.
Well, I can piggyback on that one. We've had some similar experiences. Maybe we should do some group therapy together. So starting with the Healthy Steps model and implementing maternal health into the discussion and into the practice, as I stated earlier, was not an easy task, because the mindset was, well, we're here for the child, so why are we even talking about caregivers? And so advocating for the knowledge and understanding that babies, as Winnicott said, there's no such thing as just a baby, only a mother and a baby. So, and of course now other caregivers, but advocating that, without the mother receiving the mental health services that they're asking for, we pass down so many different situations and circumstances to the child. and that the child's health and well-being, and you're not just here for the physical health of that baby, you're here for the well-being of that baby, the whole child. And the whole child means the whole family. So addressing those needs and advocating for that mindset change took a lot of work. And, we had, as with any new theory or approach, we had low-hanging fruit. So we just went for that. And then as I learned throughout my career, that once you get some buy-in and people start chatting it up and they start telling the stories of when they ask the questions and then they learn to listen, what they heard. And then their colleagues decided, well, maybe we should be doing that too. Because I don't know if you're aware, but in medicine, there's some real competition. And I'm a very competitive person at times. I'm so laid back, but on this issue, I was very competitive. I'm going to get you there. I'm going to drag you there. I just need to figure out, and here's my psychology training, where's your next step for readiness to change? And I will start there and I'll guide you individually through your steps and your readiness to change. And I'll back off when you look scared, and I'll be there to support you through feeling scared. And it really was that they just didn't know what to say or how to say it, and what might happen next, and how long was it going to take in this visit if we started talking about this. And I only have so much time. So kind of shepherding them through a different way of conducting. In our model, it's the well child visit. So a different way of conducting the well child visit. And then, as you said, referring off when we thought there was a bigger need. And also implementing the EPDS right in the well child visit and using that as our jumping off point to talk about difficult discussions, topics. But the reception we have received has been amazing from the caregivers. That's not where the challenge is. No, they didn't feel like we were in their business. They were waiting for someone to ask and someone to notice the facial expressions and the flat affect. They were waiting. So all we had to do was make a supportive comment, and there it was. So that's kind of how we got started and how we managed it. And then it just grew from there.
And I'm very aligned with Deanne. Obviously, Deanne is on the ground and I'm at our national office. And so I just popped into the chat just the data and outcomes from the work that Deanne just described, if folks are interested. Thank you, Deanne, for sharing.
Sure, I will fit that in soon, Elizabeth, the outcome pilot. Yeah, it gets better. Hang on.
So I'll talk just real quick. So Canyon was doing behavioral before I showed up. The model that was being used, ideally kind of what we would love to do, is to have the social worker or the behavioral health consultant within the office, so that a provider walks out of a well child and they're like, hey, we've got a high PHQ, can you step in for a few minutes, do an assessment? What are the resources? Some things like that. And it works really great when you have someone that's able to kind of step in and do that as needed. But that's not what happens all the time. Currently, it's just me, and I only work a couple days. And so most of my time with families is scheduled. And so right now it'll be, something will pop up from a provider. I always ask that they meet with their primary care first, so that we're ruling out anything kind of medically. The providers have usually already done like those initial assessments, like their MChats, or they've given a family of Vanderbilt to follow up with me. So kind of that ground level is already there, and then I can step in to help support kind of where is going to be the best spot for this kiddo or support for this family. So sometimes our providers will run like some lab work, checking like vitamin levels, hormone levels for our teenagers, that can play into some of those concerns sometimes. Sometimes it's a note from a provider saying, hey, this family needs a resource for, they came up with housing difficulties on their social determinant of health screener, or things like that. So I limit my visits with families to about 3. I have them come in for about a 45-minute appointment. For our first appointment, we do a whole background, kind of what's happening, what's maybe playing into this. Are we looking at, maybe a kiddo popped up high on their PHQ-9, which is a depression screener, but we're finding that it's not clinical depression. Their dog passed away last week. And so it's, is it working through a little bit of coping skills, psychoeducation, sleep hygiene, healthy, lifestyle, things like that. And then if we kind of feel that this is going to be something that we can work with together, then that's great. We'll, work our plan of care, run it by the primary care provider. If that checks out, that's great. Do this for, 2 weeks, come back, we'll see if things are working, or, if we need to modify a little bit. Sometimes we just find that there's a giant history of trauma. And so I am going to refer out for specialty behavioral support, because I know that this is going to be an ongoing concern. But I can be there to help support in the interim, because like it's been said before, it can take a while to get in to find a mental health provider. And sometimes the wait lists are really long, or they don't know where to go, or they're having difficulty finding where their insurance is accepted. And so I can help navigate a little bit. And that's kind of what we do here. So.
Thank you all for sharing all that. And our final question, we have about 2 minutes each to answer, probably more. And if this is redundant for some of you, because some of you have answered, possibly, but question 3, what challenges did you have while integrating mental health into primary care in your area of practice? And then what have you learned from that? So I know that some of you touched on that a little bit, but.
I can start with that one. Well, what I learned and our team learned is that it takes constant advocacy and constant reminder. Just don't leave the table. Whether you're talking to a provider you're working elbow to elbow with during a well child visit, whether you're talking to administrators within an organization, or whether you're talking to policy and funders, maybe. Healthy Steps in Arizona is funded by First Things First. I'll give a shout out. And that has provided many opportunities for us to be at the table, but stay at the table and keep talking about it, because the challenge is immense, and it's easy to get lost in the shuffle. And I will quickly say that we did participate in a 5-year outcome pilot study looking at our rates for completing postpartum depressions during well child exams. And in the first 2 weeks of looking at that, we came up with, we were completing 43%. And by the end of the outcome pilot project, we have sustained our gains, and we now stay in the 92 to 96% completion rate for postpartum depression screenings in our pediatric care setting. And I will also say that I am the last 12 years I have been working with Summit Healthcare in Show Low, Arizona. If we can do that in a rural community, go for it. Challenge on. You can beat us. Because I don't know if it's going to be easier, but boy, that was it. That was the gold star for us. If we could achieve that, and we worked with 0 to 3 and JBA Associates to achieve those goals. And we are so grateful. And if we can do it, you can do it.
Now, I'll just add to what Deanne said. There has been an immense amount of work that she did. So I feel like it didn't just happen. It was a lot of work every day. And I just also wanted to a little bit piggyback on what Ashley was saying earlier. Sometimes some challenges, at least for the practitioners, are what level can I go into this with mom right now in this space, right? Because we're in primary care. Primary care pediatrics is quick. The visits are short. You have to fit in so many visits per day to just meet your budget, right? So how do we ensure that both we're with the family, they're heard, they're present, we understand what's going on, and see the next family? So a lot of healthy step specialists that I've heard from too have said they try and hold that space of making that decision. Is this going to be a really long conversation? If so, how do I talk to that mom right now and hold her and try and set up something for more continuity of care? And as Ashley said, connect them to more intensive outpatient services. So I just wanted to, Ashley, I hear you, and that decision making is hard too. Maybe not for Ashley, but I've heard it's challenging.
I can go next because yes, it's definitely very challenging, especially on the physician side of it. You know, we only have so much time to cover so much in a well visit, but I obviously am here. I wholeheartedly agree that the mom and parent and family health is so important. So I think having a system in place, like Deanne said, the EPDS is a great screener, and moms want to be asked. They want to talk about it. It's not intrusive to them at all. And so we just have that as part of our workflow in our well visits. It's a survey that's automatically pushed through the sign-in paperwork. So if you can make it part of your workflow, that minimizes one less handout you have to give at the office. It's already pre-scored and populated into our well visit templates. So making, other parts of it efficient so that you have more time in the visit to actually address it. I think that's helpful. For us, with integrating behavioral health services, just a couple of things we learned. Big thing and what we're working on with restructuring is scheduling. So one thing we were a little bit surprised by is, we hired 2 providers that obviously want to work office hours 8 to 5 and be home with their families. But the families we were serving wanted to come in the afternoon and evenings and on weekends because they didn't want to disrupt their child's school schedule, or they were working and couldn't take that many days off work. So looking for having some of those alternative times available for families to accommodate them was something we hope to do in the future. Securing funding outside of what patients can pay, because there's not enough, to support, I think, truly of what we wanted to do. So in the future, we're going to look for funding to offset to be able to provide scholarship program or sliding scale, or potentially, have insurance coverage. And then last thing, just as a primary care practice, having a dedicated person to work on scheduling and billing separately for mental health from the pediatric medical side of it. Someone who could, watch payments, watch our budget, and also watch that scheduling was being done appropriate. We have a fairly large private practice with 5 front desk schedulers and 3 billers. So having everyone do a little bit of it got really confusing. And I think in the future, having just one person that was dedicated and learned and experienced with it would be really helpful. And then last thing is EMR. So we made the mistake of putting our providers, our LCSWs, on our big pediatric EMR that is very expensive and not necessary for what a therapist needs to do. So we learned that it was 1/5 of the cost to just buy a simple EMR for them to use, that we could scan their notes and upload them into ours. And that saved us a lot of money. So that would be something, for anyone looking to try to integrate it to cut costs there.
Does anybody else have anything they want to add to that? I've got a couple more questions. Um, what advice would you give to practices who want to integrate mental health?
Well, I can start that one because we did just come out of this 5-year outcome pilot. And what we learned through that process is the importance of buy-in. So ask providers what it is they would like to see change around maternal health in their own practice and what they think that they can do to create that change. So again, you're hearing exactly what we do with parents that I do with providers, and that's find their readiness to change point and go from there. Don't try to say to them, you should be doing this because of that, and here's the data to support that I am right and you're doing it wrong. And I only say that because I've seen it so many times in different practices. I've trained 32 healthy steps practices in the past. And so I have seen that where you're trying to pull them along and shove them along. And it really flies in the face of their level of comfort talking about these things and just that alone, but also in the comfort of, as everyone has said, well-child visits are only so many minutes, and there's so much expected of providers in those few minutes in order to be paid for the service. And so asking them to add one more thing, that's not the way to go. Asking them to look at what it is they'd like to see and how we can help you make that change by little adaptations to the way you're doing things. And it may be workflow. You touched upon that. And I think that's brilliant because absolutely workflow can be improved. We showed that. Our providers were like, whoa, this is great for our business model. And which, they get hammered on all the time from our administration. We're in a hospital outpatient clinic. So they hear it all the time, how we're losing money. So help them make the argument to make more money by being more efficient with their time. And also not having the burden of worrying about these caregivers because they do worry about them. And I mean, pediatricians are amazing people. And that's why I love working in that discipline because they all care and they all love every single one of their patients and their family members. And I love that. So, help them worry less about their families and know that they have made a difference where the difference makes a difference. Not just the physical well-being of the baby.
Thank you, Deanna. I'll just add to that because I think that's key is most providers, physicians, nurse practitioners, I think anyone seeing kids really cares about the family. They're just limited by what they have available to offer them. So if you can speak to that of like, here's something you can provide them, here's a way to do it. I think that's going to be buy-in for most providers because a lot of us feel a little bit lost in how to help these kids and families who are months out from a therapy appointment or struggling and don't know where to go. The other thing is, if you aren't at a practice that has mental health integrated, creating a list of what's available in the community that's easy to hand to families right in the visit. And I think Ashley touched on that. Just knowing what resources are available. It might take a little time to create that list, but if you don't have the 40 minutes to talk about, what exactly they need or dive deeper, at least you can guide them as to where they might be able to go to for help. If you don't know where to send them, they certainly don't know where to go either. And when you're in the thick of postpartum depression or your kid's really struggling, it's hard to find the time to do that yourself or even the mental capacity. So you can help them a little bit in that way.
Those resource lists have been really handy. Some of the in our practice, we have, I think, 6 or 7 providers right now, but they each practice a little bit differently. So some of our providers do half-hour appointments for every visit for every child. Other providers are 15 minutes. And so the way that I work with them is a little bit different depending on the way that the provider practices. Now, there's some things like the EPDS or the PHQ-9 that are built into templates that we have for like the wild child and things like that. And so that workflow is kind of set up. But I find that my individual rapport with the different providers has been really helpful in helping them to kind of see that what I do is helpful, right? Sometimes it's like, oh, there's Ashley, she is busy or doing, whatever, but it's nice to be able to sit down with a provider and say, hey, this is what I found in my assessment. What did you notice about this kiddo? Are we wanting to refer out? Do we want to, try a med trial or something to that effect? And the more that I am able to come to the provider with curiosity and wanting to collaborate instead of, I know, whatever, they're much more willing to talk to me, to work collaboratively with me, and that's been an important kind of part of that too.
Ashley, there's a question specifically for you in here. Canyon Pediatrics is quite unique in being owned and managed by behavioral health providers. Could you talk a little bit about how that informs the care in your practice to families, and where do you see the differences?
So my husband and I are both social workers, and we have Canyon. Some of the things so my husband Richard worked for an FQHC with their integrative kind of piece or component. So some of the things that he's kind of brought to Canyon since we acquired it a number 3 or 4 years ago is that we do sliding scale for all of our visits for families, and that's been really helpful in helping to get people seen. Some case management if they need help applying for access or they're not really sure how that works. A large portion of the population that we work with is Medicaid. There's also, we work with about 60% of our population is Spanish speaking. And so we make sure that most of our providers, that all front desk, that everyone in call center, that anything we post on a wall or a door is always in English and Spanish. We do find that there is an emphasis on, and I'm sure all pediatric offices are really kind of patient-centered. And I think that social work in and of itself has provided training for that global or holistic perspective that maybe not all people are kind of exposed to kind of in their training or things like that. But when something pops up, I think that we really do try and help out where we can, just kind of like anyone else. But
Thank you. Deanna and Elizabeth, there is a question for you two as well. Could you please explain the Healthy Steps model for us, and what does that look like at Summit Healthcare?
I think I can. 23 years in, I hope so. Great question. Thank you for asking. At Summit Healthcare, we look a little bit differently than the national model currently. The national model brings psychologists into the Healthy Steps role, and referrals are given from the pediatric practice typically. Is that right, Elizabeth? I'm not speaking from my practice, so I'm
No,
speaking
no,
from national.
child development experts. So
And okay,
the background is really a child development expert. So it can be varying levels of in terms of your degree. It's
okay.
experience with kids and families.
But to the point earlier, sustainability is a huge issue, and Elizabeth works very, very, very hard on that, and we appreciate that because we're seeing some success in Arizona. Um, we are a pilot for Arizona now at Summit Healthcare, and I'm working very hard on the billing and reimbursement for Healthy Step services. That's not an overnight process. That we've been doing this for a year intensively so far, and are just getting to where we can match the billing codes to the services we provide. So the services we provide at Summit Healthcare, as I said, we are in Show Low, so we are in a very rural, remote area. And so finding Healthy Steps specialists who are qualified with a master's degree can be quite challenging. So we do have master's and bachelor degreed Healthy Steps specialists. They are expert child development specialists. They did not just come out of college. They have some expertise behind them in working with families and integrating with pediatrics and with working with working knowledge of child development the first 5 years of life. So the way that they work is they accompany the provider of the well child visit from the time the baby is born and that first hospital follow-up visit until the child is 5. And in many Healthy Steps practices, it's to 3. But in ours, because of our funding requirements, we go till 5. And for 4 and 5, we really only make sure that they are plugged into services and in preschool. And if they are not, we are talking about school readiness skills and making sure that they all have updated child development screens, ASQ, ASQ, SE3, or SE2, on ASQS, ASQ3, and that they have all of the resources the family needs that they might identify they need. We connect them with resources to meet those needs. And that behavior, number one, behavior. So is on task because that's going to be the predictor of success in the early years of school, right? Yeah. So we're making sure resources are given if there are those concerns, or that we consult. I do a lot of consulting with behavior concerns of 4 and 5-year-olds to get them ready for kindergarten. So the Healthy Step specialists will provide all of the screenings. We are not so blessed as to have them in our automated system just yet, so that they are screened before they get to the visit. That's like a dream that's out there somewhere. But, small hospital, only so many IT resources. So there you go. And the Healthy Step specialist will review the screens in front of the families and talk with them about it. So I do think that's a richness of providing those screens, is every family is able to have a discussion with their Healthy Step specialist about screening results. And they're able to ask targeted questions that they are trained to ask, and they are trained to give that response in a helpful way, a supportive way after they receive information from the family. So that only helps us build relationships with families early and quickly, because we have to do those two things. And so we follow the families by giving periodic screenings. We have a schedule for screenings with every screen that we give. And the Healthy Step specialist works around the provider. So there's no downtime in a well child visit in our practice. Nobody's waiting for a provider. Nobody's waiting for immunizations without filled time by the Healthy Step specialist. So we are weaving ourselves into the existing model. So it does not take more time. And we have data to show that. We are able to ask pointed questions about what are the challenges of having a child this age, and what are the things that you most enjoy. And lots of conversation comes about, lots of teachable moments. Of course, we have a child in front of us. Lots of behaviors happen in a pediatric visit, and we're able to build off of those as our stepping stone. So that's what Healthy Steps looks like at Summit Healthcare. And they run fast. Our Healthy Steps specialists see about 400 families a year. our numbers are big and our time is well spent. Did I answer that
Elizabeth,
question?
Yeah,
yeah,
that's great. And Deanne, I wanted to just add from a national perspective too, practices are different sizes. And so we rely on the expertise of each practice and know that those practices know their communities. They know which parents need which level of care. So it's a population health risk stratified model. So at small practices, Healthy Step specialists can see all the babies, all the kids 0 to 5. And at bigger practices, you need to risk stratify. So decide which families you need to spend more intensive time with and join them for all those well child visits and all the visits in between. And which families, maybe they have a little issue with sleep. Maybe they have something that's coming up with behavior that they need to address in the moment. We kind of call those like the pink flags, right? The families where it's like something came up and you want to address it now so it doesn't become a bigger thing, but they don't need all the comprehensive services that are sort of with our, we call it tier 3. So that's the most comprehensive. So tier 2 is more a few consultative sessions with families, supporting them as they need it, kind of bolstering, helping them along. And then tier 1 is what Deanne described with all the screenings. So it's practice transformation in that we expect that all practices implement universal screening aligned with the AAP Bright Futures. We understand that that is a lot of requirements, yet not the tools or the manpower, the people to like really operationalize. And I'm sure Dr. Bowman knows all about that. And same with Ashley. So we try and help practices get to where they want to go in terms of all of that. So just wanted to add that, Deanne.
Thanks.
thank you. We have some time for questions. So I'm going to ask Raquel to check the chat. And
We had
see if
one
everything-
question. I think it was kind of touched on, but Deanne specifically, how do we find out the readiness to change providers and practices, to change of providers and practices?
Ask them. Where do you want to go next? What are you comfortable doing next? That's what will help you do.
So thank you.
And we'll step you through this and we'll be right there with you.
That's great. There's another one. What do you think are the major barriers to other practices in getting integrated care into more practices in Arizona? Is there any policy work that needs to be done?
Policy work needs to be done. And if anyone wants to work on it, I'm right there with you. We need payment, right? And the rest of you feel free to speak up, but that is full stop my answer.
Yeah. And we're well on our way. You know, keep tuned into us in Sholo because great things are coming. But the work that 0 to 3 and First Things First leadership have accomplished at Access has been monumental. I have worked on this for more than 20 years in Arizona. It was harder when I went to the rural community because I wasn't at every meeting like I was when I was at Phoenix Children's Hospital. So I think we kind of got lost in the shuffle, and I just didn't know where to go. But with the help of those 2 agencies, we got there and we got to the table and had a really nice discussion. And we've had really good outcomes from that. And so billing codes have been opened up. We'll see. We're going to test them coming up really soon, and we'll see what happens. But that 40% that Dr. Bowman talked about is a reality. And that's for a licensed clinical social worker. So now you're talking about a healthy step specialist that is not licensed. So it's even harder. But I do know other home visiting programs have received reimbursement. So, you know, we are the medical model. Hello. It's a no-brainer. And we are also building cases to show the impact so that people understand at the policy level the impact of healthy steps with families and on children's health. Unfortunately, children's health gets lost a lot in discussion. And when you're talking about infants and toddlers, they really get lost. But we are also supporting HEDIS measures, which people care deeply about at the policy level and the funding level. So keep an eye on us.
Thank you so much. I think that's all the questions I see in the chat right now. If anybody has any other questions, feel free to raise your hand. We'll unmute you.
I think Alina was going to answer this one too.
Oh, perfect. I'm sorry.
No, that's okay. I was just going to echo the payment side of things and reimbursement, not only for mental health, but pediatric care as well. We're one of the lowest paid specialties in medicine. And, to just run our business, sometimes time with patients is the thing that gets sacrificed. And so, advocating for better coverage of well child visits, services provided by pediatricians and pediatric therapists, I think would be huge, and also beneficial to maternal health, because again, we're the people that can see them, from day one and help right away. So just wanted to echo and yes, agree with Deanne and Elizabeth.
Thank you. Josephina has her hand raised, so go ahead and unmute yourself and ask whatever you'd like. Oh, she wrote it in
The question
chat.
for fatherhood.
Yes.
Yeah, that I just answered that. And yes, we have had fatherhood specialists in our community before, many. And in Phoenix, we had them as well. But sometimes there aren't very many of them, and there are a whole lot of daddies. So that's challenging. And like I said, in a rural community, it's just so fluid. People move in and out and ebb and flow. And it's really challenging just to keep, afloat with what we're doing. And then to add the other specialty care, we know it's important, but we just don't have resources there. And oftentimes our healthy step specialists have to fulfill those needs. So they wear a lot of hats in a rural community, and we just train. I have a huge training budget, and that's why.
I'm sorry. As soon as my son is finished with nursery school, he said he will be more involved because he is a new dad. So there you go. Sign him up.
So wonderful to hear that. I just wanted to thank all of our panelists. I am so inspired by the work that you're doing, right? Like you're running against the grain, trying to integrate something that we know is critical and vital to maternal and child health, and running into, so many hurdles, and you keep going. So thank you for the work that you're doing and trying to figure this out. I mean, you definitely are trailblazers. That's how I feel about each of you. So thank you so much for the work that you're doing to try to get this to work. I know that at some point it will work, right? That's what I tell myself about all maternal and child health. And in order for us to see it, we have to envision what it should be, and then we have to start making steps toward it. So thank you for being those trailblazers and making those steps. It's amazing to hear what you're doing.
Thank you, Jenny, for staying at the table. I know where you started, and this is just incredible. My heart is so warm that this is where you are today.
Thanks, Deanne.
Okay, if there are no more questions in the chat, I want to echo Jenny's thank you to our panelists for being here and answering all these questions for us. And a reminder to the participants to share your favorite Arizona organizations and resources, practitioners, family supports and advocates on the HUVA community board, so that you can build your network and connect with everybody and earn points to win our awesome prizes. And I just have a couple reminders before we move to our break that don't forget to be active on the Hoover platform, like I said, so you can connect with others. Take a look at your leaderboard to see where you land. And we are going to resume at 11:05. So we've got a short break. Stretch your legs and see us back here at 11:05.